My name is Jerry Dang, and I'm one of the general surgery residents at the University of Alberta. I'd like to thank you for giving me the opportunity to share research on predicting major adverse cardiac events following laparoscopic bariatric surgery. I have no conflicts of interest to disclose. Obesity has been increasing in prevalence worldwide, and the most recent estimates suggest that 650 million people are obese. The prevalence of obesity, as shown on this prevalence map from the World Health Organization, is predominantly in Western countries, with quite a high prevalence in countries such as the United States. Obesity is associated with cardiovascular disease, and patients with obesity have a higher risk of cardiovascular events, including diseases such as myocardial infarctions, congestive heart failure, arrhythmias, cerebrovascular accidents, and cardiac arrest. Due to increasing rates of severe obesity, as well as strong evidence suggesting the weight benefits, as well as the improvement in risk reduction of bariatric surgery, bariatric surgery is increasingly performed. The two most common bariatric procedures currently performed are the laparoscopic Roux-en-Y gastric bypass and the laparoscopic sleeve gastrectomy. This is an excellent study done by Dr. Aminian, which demonstrated that bariatric surgery can reduce the risk of major adverse cardiac events. What they found was there was a reduction in the hazard ratio of 0.59 after bariatric surgery, and this included some patients with quite a long follow-up period. However, what we want to do is we want to look specifically at the short-term risk of major adverse cardiac events after bariatric surgery. We want to identify factors that were associated with these events and develop a clinically useful tool to predict the probability of 30-day MACE after both Roux-en-Y gastric bypass and sleeve gastrectomy. We did this by employing the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program database. This is a clinically rich database that collects data from up to 854 bariatric centers in the United States and Canada. It captures clinically relevant variables for metabolic and bariatric surgery, and it collects about 95% of all bariatric procedures occurring in these two countries. We extracted data from the 2015 to 2018 MBSA QIP participant use files. We only included patients undergoing sleeve gastrectomy or Roux-en-Y gastric bypass, and excluded anyone who was under the age of 18 years, who've had previous bariatric surgery or foregut surgery, and who was flagged as undergoing emergency surgery. The independent variables included in our analysis included demographics, such as age, sex, and BMI, perioperative variables, such as operative time. We included all the comorbidities included in the database, as well as history and functional status, with important ones being a history of previous myocardial infarction, previous major cardiac surgery, and previous percutaneous coronary interventions. Our primary outcome was a composite variable of 30-day major adverse cardiac events, which included myocardial infarction, cerebrovascular accidents, congestive heart failure, arrhythmias, and cardiac arrest requiring cardiopulmonary resuscitation. For statistical analysis, we did a multivariable logistic regression to determine the predictive factors of 30-day MACE. We used a purposeful selection algorithm in our univariate analysis, just like for variables we include in a multivariable analysis. And then we included all the variables mentioned on the previous slide and excluded post-operative complications. Surgeries performed in 2015 and 2016 were used as the derivation cohort for our predictive tool. Once the predictive tool was created, this was validated against the 2017 and 2018 cohorts. We calculated the area under the receiver operating characteristic curve to assess for the predictive ability of our tool. We included 430 laparoscopic sleeve gastrectomies, 156,000 root-wide gastric bypasses. Of these, 0.13% had a major adverse cardiac event, of which 204 were myocardial infarctions, 88 were cerebral vascular accidents, 230 had a cardiac arrest, and 255 had congestive heart failure or arrhythmias. Our multivariable logistic regression found these factors that were associated with increased risk of MACE. However, we'll focus on our predictive tool, which focuses on these 9 variables, the highest of which was therapeutic anticoagulation, followed by renal insufficiency, history of myocardial infarction, hypertension, hyperlipidemia, insulin-dependent diabetes, a higher body mass index, a longer operative time, and older age. These are calculated into a total score, and patients with a score of less than 67 have a major adverse cardiac event rate that's less than 1%. However, if the score is greater or equal to 67, then they're considered high risk with the event rate of greater than 1%. We calculated our area under the receiver operating characteristic curve, and our tool performed quite well with a validation statistic of 0.78, a derivation of 0.8. This correlates with a sensitivity of 12% and a specificity of 98.3% for MACE. In conclusion, major adverse cardiac events after laparoscopic bariatric surgery has a low overall event rate of just 0.13%. However, some patients have a higher risk, and our predictive tool allows for the accurate stratification of patients into low and high risk categories. This tool allows for informed clinical decision-making, as well as it helps patients to understand their own personal risk. High-risk groups may need more monitoring with postoperative cardiac monitors, daily troponins, and daily ECGs. Some of the limitations of our study, however, included a lack of granular data on the severity of heart disease, on studies on heart function, or patients who required cardiac medications. There's also a lack of data on existing heart failure or existing arrhythmias. I'd like to thank my co-authors as well as the University of Alberta, and thank you for listening.